greetings everyone. Welcome to the 157th session of the online Optom Learning Series, or OOLS. And for today's session, we have with us Dr. Shalu Pal. Dr. Shalu Pal has graduated from the Southern California College of Optometry and then went ahead and completed her contact lens, cornea, and disease residency as well. She is a fellow of the American Academy of Optometry, a fellow of the Scleral Lens Education Society, and also a fellow of the British Contact Lens Association. Currently, Dr. Pal is the owner of a group practice in Toronto, Canada, which specializes in advanced specialty contact lens fittings, myopia management, dry eye management, and all treatments, I would say, under the area of optometry, vision therapy, ocular aesthetics, and I think a practice provides all care of optometry which can be under the roof. She is on the advisory board of multiple organizations. I think you can see everything on the slide. She's helped me to put up that on the slide, so it's easy because the list can go on and on. And her specialty is fitting specialty contact lenses and scleral lenses. She's an international speaker, has published extensively, has worked for voluntary work for both local and global organizations for the betterment of the profession, optometry, and those in need of eye care. So today, Dr. Pal is going to share her experience of over, I think, 16, 17 years of fitting scleral lenses and how to help patients with dry eye while fitting scleral lenses. So welcome, Dr. Pal, onto our platform. And let me just leave the screen time to you.
Thank you so much. I'm so excited to be here with all of you. Thank you for inviting me. I have been learning more about your group, and I'm so impressed with what you guys have put together and how you guys have come together to do this. So thank you for including me, and thank you for bringing me to this event. Over the next hour, so I want to just talk to you about scleral lenses and how they've impacted my practice. I'll tell you a little bit about my practice. As it's been mentioned, we have 5 doctors in the office right now, and each one of us have our own subspecialty. I've been fitting scleral lenses since 2005 when I started to learn about them during my residency. I drove to this small little town, and there was a lady in her basement grinding lenses, and I went in and I said, "What are you doing?" And she's like, I'm trying to figure out how to make these large lenses. And that's where my education started. With respect to scleral lenses, oh my God, it's changed so much over the last 10, 12 years. It's incredible how much advancement we've had in this area. And so I'm excited to go through a couple of different things with you today. So as optometrists, as eye care providers, I think, just starting off with what is the purpose of what we do? And for me, my purpose is to make sure that I take everything that I've learned, all my expertise, and I want to try and make the lives of my patients better. That's the philosophy that we live by in the office. Everything that I do in my office is about making them more successful, making their lives better, doing everything in their best interest. And scleral lenses has really made such a big impact with respect to that. Let's talk a little bit about dry eyes. I'm not going to go into dry eyes too much, but that's the premise of why we're here and to figure out how scleral lenses can help these patients. When I think about my dry eye patients, I really have 2 main categories. I have the patients that are in my practice, and then I have people that are sent to me. With respect to dry eyes in the office, I've been studying dry eyes for almost 8, 9 years now. And it started with, I just wanted to learn more. And at that time, we didn't have very many options. But today we have so many options. I am very, very fortunate that I have almost every tool that you can think of in our practice, because I want to keep learning and keep expanding. So we have LipiFlow, we have BlephX, we have IPL, we have radio frequency, we have amniotic membranes, we have access to all the different medications that are available. So treating dry eyes is really exciting, but scleral lenses are a huge part of that. When I think about our dry eye patients, the ones that are referred to me are patients that have tried everything and they are struggling. And typically they are coming to me because a lot of people don't fit scleral lenses. So they've come for that specific purpose. In my practice, when we think about dry eyes, I think all of us are suffering from dry eyes, especially with how much Zoom time we are all doing. We're not blinking enough. When we think about our kids and the little ones, they are given these devices so early on that they're just not learning how to blink. And all of that's leading to so much dryness. I also think about these people as being exhausted and frustrated. And they're just such an emotional component to the dry eyes. When I think about scleral lenses, I'm so curious where people think about it. For me, I know exactly when I'm thinking about offering scleral lenses. But for other people, sometimes they don't think about it at all as a good option. I was speaking at a conference maybe 2 months ago in Alberta, Canada, and I was talking about scleral lenses to a group. And the majority of them there had no idea that scleral lenses could even be a good option for dry eyes. So it's a very different mindset compared to where I'm at versus a lot of people. When we think about the do's too, a lot of you have seen this already. We know that dry eyes is a combination of aqueous deficiency and evaporative. And we know that it's somewhere, you've always got a little bit of both. And if we look at the individual steps, what's really nice to see is that in DEWS 2, we actually have scleral lenses on this platform right here at step 3, because in DEWS 1, scleral lenses wasn't even mentioned at all as a potential option. For me specifically, I'm thinking about it so much earlier, and it's because I also fit them, right? So it's easy for me to be thinking about them more, but I'm thinking about them for those patients that are constantly putting drops in their eyes. I've had patients come in that are referred that are sitting there in front of my chair and literally blinking like this, constantly blinking, and they don't have any relief from their natural ability. I remember putting lenses on these people, and for the first time, they're looking at me and they're going, I'm not blinking, right? I'm not blinking. I feel comfortable. When you have a few of those experiences, it really starts to put your mindset into how powerful scleral lenses can be and how much comfort that they can give because of that tear reservoir that's underneath the lens. So I tend to think about them right from the beginning. I'll also, when I'm doing my dry eye workup and I'm thinking about what's my plan for you and what's the treatment protocol that I'm going to think about, I'm also thinking about planting a seed. It may not be what the patient wants immediately, but it may be something that we think about later on or we bring into the mix at another point. Costs always do come into a factor, and scleral lenses are not an inexpensive endeavor. But when we consider sometimes ongoing care of continuously doing something, the quality of life that we can improve by having a contact lens solution, I think is wonderful. And it's something that I definitely am thinking about right from the beginning when I'm talking about them. Let's dive into a little bit more about scleral lenses. And, please, I really do want you to be thinking about questions that you have for me. We're going to leave lots of time at the end. So whatever specific questions you think about your experience, do let me know, because I really want to be able to help you in any way that I can. But when we think about scleral lenses, they're a large diameter lens. There's good centration. There's good comfort. We get really good vision because that fluid under the lens fits and fills in all of the irregularities of the cornea. We also get a lot of protection because that wind that's blowing in our eyes or dust and debris, we're protecting the cornea from that. And obviously the biggest piece that helps with respect to dry eyes is that fluid that's underneath the lens that's giving that lens that constant hydration. There's a study, it's called the Scope 1 study. And the Scope 1 study looked at how are practitioners using scleral lenses. And what's really interesting to see is this is how I started my practice. When I started with scleral lenses, I was really thinking about those irregular corneas, the keratoconics, the transplants, those people that have such irregularity that I need to create a brand new shell over the cornea. And that's where I started. And then once I started learning about dry eyes, and then I knew I fit sclerals, I said, that is the next direction where I can use my scleral lenses to help. Those Sjogren's patients, those severe dry eyes, when you look at a cornea like this photograph here, you think about steroids, you think about moisture drop, you think about ointments, and sometimes that's not even enough to clear this cornea up, right? Because of that constant damage. But when you have a scleral lens on top of this, you have that continuous moisture on top of the surface of the eye. So that's where the practice started to move. And 16% of scleral lens fits right now are being done towards dry eyes. I think we're going to see this number go higher and higher as we start to see more people starting to fit scleral lenses, because there's only so many keratoconics out there, but there's going to be so many of us fitting it. So we're going to start to look at how else can we use this lens. And that last category is your high prescriptions, your high amounts of astigmatism, people that we may not have thought about for scleral lenses in those early days. Now I'm thinking about scleral lenses more frequently. People who, are soft contact lens wearers that, are now saying, yeah, my eyes are dry. I don't really like soft lenses anymore, but I still want to be in contact lenses. Let's fix both aspects. Let's give them the comfort of the contact lens, but also help their dry eyes as well. So, I laugh when I have a dry eye patient that I'm going to be fitting with sclerals versus a really large keratoconic patient. Sometimes I think the keratoconic is so much easier. That dry eye patient has so many emotional components to their experience. They have suffered a lot. They have gone through a lot. They have tried so many things. So sometimes I find it much more challenging to work with these. I have one patient, her name is Mia. And honestly, she would come into my exam and she would sit, and for 40 minutes, she would cry. She would remind me of everything that she's gone through. She would just need to get it all out. And then she would say, okay, I'm done. Now you can do your work. And it was exhausting. It was honestly exhausting. And when you fit scleral lenses, it's not a quick one visit and we're done. There's multiple visits and it takes time. And this process with fitting her was a lot of work. But at the end of it, it was so rewarding because we got her comfortable. And it took some time because she was so skeptical that I was going to be able to help her. But by the end of it, when we were able to get her settled and she walked out of my exam room smiling and happy, her dad pulled me aside and he said to me, thank you so much, because Mia doesn't talk about her eyes anymore. Every day she would cry about her eyes. Every day she was in pain. Every day she was in discomfort. But now she doesn't do that anymore. And she goes, and he was just so grateful that that's what we were able to do. And that's what the magic of scleral lenses can do for our patients, where we take these people that are in so much pain and discomfort and we're able to help them. But you got to be ready for it because it can be tough and it can be challenging. One of the key things before you ever start with scleral lenses is you really need to look at the ocular surface and make sure you have no debris and you clear up all of this MGD, all of this blepharitis, these allergies, all of this stuff that can make your scleral lens fitting more complicated. What makes it complicated? The front of the surface will get all gooped up and all this debris will land on the front. And all of this mess will also get underneath the lens, and that'll create fogging and drama and issues and more infections and more redness. So when I see a patient, I'm not just thinking, okay, how do I fix and fit a scleral lens for you? I'm thinking, what else is going on that could potentially make my scleral lens fit complicated? I'm going to clean this all up first and make sure we've dealt with all of this lid stuff before we dive in. And then once we start with the fitting, I want to make sure I have really good baselines. I want to make sure I know exactly what their eyes look like before I start. So obviously staining the cornea, seeing what type of staining pattern we have, how much dryness we have. But I really like to also take a look at pachymetry and make sure I know how thick is that cornea, because I want to make sure that I'm not causing any swelling. We know that when we go to bed every night and we close our eyes, our lids cause that cornea, our corneas, to swell overnight. Well, when we wear a contact lens, a scleral lens, our corneas can also swell. So having pachymetry readings is really important. As much documentation that I can have, I try and get. And, I've been practicing for so long now, and I finally got a slit-land camera. So excited. It was like the best birthday present I could ever get. And now I take images of the cornea when I have, whether it's pinguecular or I have neo that I'm starting with, or different aspects of the cornea. I want to be able to see what that looks like before I start fitting. So that way I know that, hey, did I create a problem? Did I create a mess here? Did I create that neo? Or did I make things better? Am I making things improved? And that's what I want to check and make sure that whatever work that I'm doing, I'm not making things worse for the patient. An overview of scleral lenses, we have our central curve, we have our limbal curve, and then we have our landing zone. Different labs are going to call it different things. Excuse me. But those are the three basic curves. Underneath the lens, in between the cornea and the contact lens, this is our tear film. And this tear film, this is the magic of this lens, right? This is what gives the hydration for dryness. This is what corrects all the irregularities. So this is what I tell our patients. This is the key. This is the magic to everything. Understanding the sclera is really important. I have just gotten the eaglet into our office, and that's a scleral analyzing topographer. And it's for us to be able to do a little bit of research to see how this is going to impact our fitting process. But one of the things that we need to know about the sclera is that the further you move away from the limbus, the softer and the spongier the sclera becomes, the more irregular it becomes. So closer to the limbus, the more rigid and stiff the cornea is, and stiff the sclera is. So how that impacts things is, for those lenses that are smaller, you've got a lot more regularity around the cornea. When you have a larger lens, you have a lot more irregularity. And so things are not going to fit exactly the same. So when I start thinking about a larger lens, I'm thinking that tissue is spongier out on the edge. So I'm going to have to allow the lens to settle a little bit more. When a lens is smaller and it's closer to the limbus, that tissue is tough. It's not going to sink as much. So there is a little bit of different thought process when it comes to that sclera, when it's closer to the limbus versus when it's further away, and how it's going to impact your process. Anywhere between 80 to 200 microns is how much settling you can have. And, some people say you just need to check it 4 hours after the lens has been on to see how much settling has taken place. But honestly, I continue to watch how much settling happens over the first week, over the first month. And I bring back every patient every 6 months, because after 6 months, I want to see, okay, if you're in a large lens, there's a possibility that we are going to bring that scleral down even further over that length of time. And the key thing with settling is we want to make sure that lens is not touching or rubbing the cornea in any way. Iris diameter. So we always are taught about horizontal visible iris diameter, but one of the things that we're learning is that the diagonal diameter is actually the largest diameter. So when some fitting sets, they will tell you, I want you to look at base curve. I want you to have your iris diameter. You're going to choose your diameter of your scleral lens based on the diameter of the cornea. I want you to be thinking about that horizontal measurement, because that's the longest measurement of the eye. I'm going to go through the overview of the fitting steps just so you can see what my fitting step process is. And one thing that I have done is I have trained one of my technicians to literally be my right hand. She does everything with me, and I bet she could do scleral lens fittings without me now, because I've taught her so much. But the first step is picking that first lens and putting fluorescein into the bowl and then putting the lens on. When we put that very first lens on, I'm going to do a quick check to make sure I don't have any touch at all. So I just do a quick scan. And if everything looks good, then I'm going to let the lenses sit, and at least 30 minutes in my office to make sure that, we see what happens in those first 30 minutes. Then after 30 minutes, we're going to do topographies over top, and we're going to do K measurements, keratometry over top. I'm going to re-look at all of the directions, all of the angles, evaluate everything, and then I'll take OCT images. OCT images, I take a look at all the way across down the bottom, and then I do edge images. You don't need an OCT to fit scleral lenses. I didn't have an OCT for years when I was fitting scleral lenses. It was just my slit lamp, and it was just fluorescein and the lenses. So you don't necessarily need an OCT. Now that I have it, I'm able to be a little bit more accurate with my micron measurements. But like I said, you don't need it to get started. Then once we have the patient back in my room, I'm going to start talking to them. Tell me what you feel, because what they feel is going to give me a lot of information about the edges. What does it feel like with your eyes closed? What does it feel like when you blink? Because if they're blinking and they're feeling that edge, that means that that edge is lifting and their lid is hitting it. If they're feeling the lens with their eyes shut, that means that the lens has a lot of pressure on the eye. And so that really is a very important question of what does it feel like? And then based on what they tell me, I start looking in those areas for problems. Obviously, I'm going to keep looking at everything, but I'm using their words to help me guide the direction that I'm going to look at. Obviously, I'm going to look at the sagittal height. I'm going to look at the limbal clearance in the landing zone, and we're going to go through each of those zones in a little bit more detail. I'm going to look at the edge for leaking. The edge is really important to me. When I talk to patients about the process of fitting scleral lenses, I tell them that the most important and most complex part of this entire fitting is getting that edge to fit nicely. When I first started, we had a spherical lens. We couldn't do anything different with that lens. It was one curve, that's it. I could lift the whole curve up, or I could bring the whole curve down. That was really it. But we have so many options now, and we'll talk more about it. Remembering to look at the overall picture of the eye. So I do global views, then I check my vision, and I do an over-refraction, and I gather all of this information before I order my first lens. Because once we bring the company into this whole mix, the lab, we then start counting the clock. We have 3 months to perfect this fit. Then we're going to take a look at these lenses when they come back after wearing 4 hours, and I'm going to repeat the whole process and make 1 or 2 modifications. Let's look at each of these zones in a little bit more detail. So the corneal vault, the key things here is you don't want to have any touch at all, and you don't want to have any bubbles. If you don't have an OCT, this fluorescein is perfect because it allows you to see how much fluorescein is underneath the lens, and you can see if there's any touch just by looking through a slit lamp to make sure that everything is kosher here. When we look at it on the slit lamp, here is our cornea. This green band is our fluorescein. That's our tear film. That's where we're looking at that sagittal height. And then this black band here, that's the thickness of the cornea. So before I had the OCT, I would know what the thickness of my contact lens is. Thickness of my contact lens is right here. So my lab would tell me, okay, that contact lens is 300 microns. So then I could compare the thickness of the contact lens to the thickness of this sodium fluorescein band, and then be able to say, okay, how thick is that? Is it the same size? Then I have about 300 microns. If it's half, then I have 150 microns. Now, depending on which company you're using, they'll tell you how many microns they want you to have at the limbus, at the edge, at the very center of the lens. So use your labs to really give you the good information that we need. If you have too much sagittal height, you're not going to get enough oxygen to the eye. The vision is not going to be very good, and it can create a bit of a swamp underneath the lens. If you don't have enough, that could create touch, it could create rubbing, it could create discomfort. So the right amount is really important. And I aim for about 250. Before they start to settle, I want to be in that 300, 350 range, because I know about 100, 150, they're going to settle. And ultimately somewhere between 150 and 200 is where I want to be. Now, the limbus, that's where you want to have anywhere from 20 to 100 microns, right? So right around the edge of the lens. Now, this looks like touch right here, and this can be very deceiving underneath a slit lamp. So you want to make sure you have the patient look left and right to make sure that you're not creating a shadow, and that's what creating that limbus. But you do want to make sure that you are not rubbing here, because the most important thing is when you are rubbing up against that limbal edge, that's where a lot of discomfort comes from. If you have too much limbal clearance, that creates this negative pressure underneath the lens, and it will pull the conj underneath the contact lens, and it will just suck everything in, and that's going to create a problem as well. That peripheral curve, this landing curve. So this is, like I said, this is the one piece that's the hardest and most difficult to fit, because this is what determines your comfort. This is what determines whether the tear exchange is good. This determines whether the lens is sitting too high or too low. So this is I think the most complicated part of the lens that is the most troublesome. And again, it depends if you're dealing with a small lens or a large lens. I always think about this landing zone as like an airplane taking off. That's that perfect landing that we want to have, that nice, smooth takeoff. When we think about some of the complications that come from this is when you have a very sharp angle where the lens sort of digs in and then takes off this way. Or on the other end of it from here is if it's lifting, right? If it's lifting, that's where the discomfort's going to come from. If it's digging in, then that's where the redness is going to come from. So this whole area is the most important part of the lens. Here's blanching. So blanching and impingement are two different things, and we'll talk about this, but right here, you can see here's your conj. Here is the edge of the scleral lens that's pushing down so flat and compressing and creating a whitening effect of the tissue right there. Here's edge lift. You can see it here where the edge is just lifting up. That bottom lid will hit that edge, and that patient will say, I can feel this right here. This doesn't feel comfortable. Every time I blink, I can feel it. So that's that edge where you want to tuck it in. Impingement is when you have pressure in one spot that's actually cutting off the blood vessels. So if we look here at this large blood vessel right here, and you see right here, it's cut right there. The blood is not flowing all the way through. This blood vessel looks like it has a continuation, but it's all right in here is where that impingement is, where it's pushing down on that blood vessel and preventing proper flow. That's something you want to avoid. So if you look at this blood vessel here, it's continuous. It's not being impinged on or pushed on at all by that scleral lens. So this is that perfect alignment that you're looking for. It becomes tricky because you're not going to be able to exactly get perfect alignment all the way through. And the key thing is to make sure that you're not doing any harm. And that's where those images before and after give you a real good evaluation to make sure you're not doing any harm. Toric lenses. So toric peripheral curves help us so much. And I remember 6-7 years ago when they came out with peripheral curves, toric peripheral curves, I was like, thank you, because this is going to help with this area that's steep and this area is that flat. I can now do two different things. And then they came out with quad specific. So I have now 4 regions that I can adjust. Here you can see the markings on the lens. So there's one marking here and one marking here. This represents our flat meridian. And then the opposite 90 degrees is our steep meridian. So, looking at this OCT image, you can see the difference between the nasal aspect and the temporal aspect. Look at the difference in the pattern. And if you look at just putting a scleral lens over top of this, you're not going to get the same edge results here as you would as this very different corneal contour. Okay, so a few more quick tips. Really, really use your patience to help you with the discomfort. I like to remove the lens the first time myself, so that way I can see, is this lens really tight or does it come off easily? The lens should come off easily. I also like to rotate the lens. With the lens and the patient behind the slit lamp, I will rotate the lens to see, okay, is there any resistance here, or is it sticking, or what's happening? And then, really making sure if that lens comes back to that same spot that we originally look for. Don't forget these global views. And then here are some of the images with the OCT that you can use the OCT to help you. You can use the calculations to figure out exactly how much sagittal height you have. So here's your cornea, here's your sagittal height, the tear film, and then you have the thickness of the cornea that you can measure as well. You can look at the limbal region here and see, okay, what's happening at the limbus? Here is the edge of the lens. Here is your limbal region here. Is there touch? Is there enough room? You can do measurements there. You can do measurements overall of the anterior chamber completely and figure out, okay, how much sagittal height do I have? Because some fitting sets are going to go based on sagittal height. And you could actually calculate what's the sagittal height of my cornea and then add room for the thickness of the lens and add room for thickness of the tear film, and then calculate what your initial lens can be starting with. And then looking at the edge, you can really take a look at to see, is this a really nice pattern, which this one is? Is the lens digging in? Is the lens lifting up? And it's really nice to see those images. Some advanced things that you can do, you can put toric lenses on the front. So if you have some residual astigmatism coming through, a lot of astigmatism will be corrected by these lenses. But if you have some residual astigmatism, you can put it on the front. Experimenting with multifocal lenses. And then if you've seen before iPrint is such a customized way of making scleral lenses where you're using this impression-based molding to come up with an exact shape of the eye. So when we talk about those larger diameter lenses with that irregular sclera all the way around, and you have all of these curves and you have pinguiculas and different things, an impression-based molding type of scleral lens is really helpful because we can really, really cover all of those different areas. And you can put prism into these lenses. You can decenter optics. There's a lot of really fun stuff that you can do with these iPrint lenses. Other things you can do, you can fenestrate a lens. And the purpose of fenestrating a lens is if there's too much pressure underneath the lens and you just need to relieve some of that pressure, that tiny little hole is there. Some companies will call them channels, some will call them fenestrations, all different things. You've got notches where you can just avoid different areas of the eye completely. So if you have blebs and different glaucoma procedures and you want to avoid those obstacles, you can very easily notch a lens. I don't notch too often. I tend to do more microvaults, and microvaults is where we're just creating a little bit of a hump over top of the obstacle that we're looking at. So here you can see there's the pinguicula there, and we're going over. So what are some of the key things with respect to dry eyes do we need to be thinking about with scleral lenses? When you have someone who has very big eyes, who has a lot of conj, their dryness will, even if you have a perfect fit, you might find that, okay, my eyes still feel really dry. And it's because the conj is still not protected. So in those situations, when you see someone that has a lot of area and a lot of fissure exposure, I want you to be thinking about a larger scleral lens than maybe one of the ones that you would think of just for a keratoconic or for someone who's looking to fix a prescription. I want you to think about, I want to cover more of the conj to be able to get more coverage, more protection over the cornea and the conj as well. Complications. So there are a lot of complications when it comes to scleral lenses. And I really want to go through these so you can see some of the troubleshooting things that we can do to help. There's some key ones that come with respect to dryness, and we'll go through those. Insertion and removal, this is the thing that scare people the most and can be the most problematic. If you can't get a lens in or you can't take a lens out, how do you do this whole process? And there's so many different techniques of different devices we can use to help patients put lenses in, take them out. Insertion removal tools, you can use your fingers. There's YouTube videos on how to do this. There's lots of different methods, and it's about being creative. This system right here, it's called Sea Green. It's the Sea Green stand, and you can have this with a light or without a light. And what it is, you put your DMV holder right into this device, and if you turn the light on, this is what it looks like to the patient. So for some patients that find it very difficult to hold their eye open and then bring the lens to their eye, they can now just worry and concentrate on getting their eye open, because this is now sitting on a table with the plunger on top, and they can bring their eye right to the light, and then they have that light to help guide them. So I find this really helpful for patients that don't have, a lot of great vision without the lenses on, or that have a lot of problem with dexterity or find that they're shaky, having something to stabilize the lens for them is really helpful. Pain upon insertion. So pain upon insertion is a complication that either means that your lens is not fitting right. So that's the first thing. Something's wrong with the edge. Or we have a specific orientation for the lens where we typically put a dot in a certain location and they're inserting the dot at the wrong spot. So if you have a quad specific lens design and the lens is being put in a wrong spot, that's going to feel uncomfortable until it finds its right rotation. So knowing that there's a dot and letting your patients know, hey, we have a dot specifically put on there to help you put the lens in. Sometimes we'll put the dot at 12 so that it's hid underneath the top lid. Sometimes we'll put it at 6. All just depends on the anatomy of the eye. Solutions are really important, and you really have to have good conversations with your patients about solutions, because oftentimes a lot of our complications come from the things that they have on their hands, or, they couldn't find the product that you recommended. So they went and found something, at the drugstore and they just picked something up. Well, they thought it was okay. Sometimes patients push not enough when they're putting the lens on. And if you don't make that contact with the lens against the cornea, that lens is going to hover a little bit, and then you're going to feel the edge. And oftentimes it's like, no, don't be scared. Push the lens on and push a little bit, very gently. You don't want to be aggressive at all, but you want to make sure you have good contact, because sometimes, like I said, if they don't put it on enough, it's just hovering there and they're going to start feeling the edges. So a couple of different things that we can think about with respect to pain. Compression or impingement, we talked a little bit about it, right? So when I think about compression, I think of more of a bigger platform that's pushing straight down. And when I think of impingement, I think of more of one tiny aspect just pinching a little bit. So the compression here on OCT, you can see this is the edge that's pushing down, that flat push that's pushing, and you can see the disparity with the sclera here versus where it's being indented. So that's what it looks like on the eye, where that white compression blanching is happening. Impingement, right, is where those blood vessels are being pinched. And that usually happens right at the edge or, at a specific spot. Look at those blood vessels coming in, and then it's just pinched right there. And then the blood vessels continue. So much smaller footprint compared to compression. Either way, the lens is too tight and you have to raise the edge and flatten the edge a little bit. Neovascularization. We never want to see neo on the cornea, right? This is telling us that we're not getting enough oxygen to the eye. The eye is screaming at us saying we're not happy. So we have to make sure we watch for neovascularization, and we have to make sure that we don't put pressure. So when we think about pressure, there's negative pressure. So we've sealed off this eye with this large contact lens. And if the seal is too tight, it creates this negative pull underneath that lens. And that can happen if the limbus has too much clearance. So you've got more than that 20 to 80 microns, or if that sagittal height has too much fluid underneath the lens. When you think about 600, 700, 800 microns underneath that lens, that's going to create that tension underneath. And that's where you can have neo that develops. You can also develop edema as well underneath that lens, that pressure just creating that as swelling underneath the lens. So you want to make sure your height's not too high. You want to make sure your limbo clearance is not too high. And this is where you can look at fenestrating. Again, I'm not doing as much fenestrating as I used to, just because of those toric peripheral designs. We have the ability to really adjust these edges. Corneal staining, conjunctival staining, limbal staining. Let's go through each of these. So with corneal staining, something's going on underneath the lens. It could be because of the solutions. When I see corneal staining, the first thing I think of, did you use a preserved type of drop, either in your cleaner or your eye drop? What did you put into the eye that's creating this? Because that could create some toxicity. If the sagittal height is too low and you've got rubbing or not enough moisture, that can create staining, and same thing at the limbus. So we've just got to make sure we review the systems with the patients, make sure they're not using products that are getting underneath the lens that's creating this toxicity. And you want to make sure you have enough clearance both in the center and on the edge of the lens. Limbal staining. So limbal staining, and this, I like this photo the best right here. Look at this. This limbus is just irritated, right? So either the lens is too flat right against the limbus and it's rubbing, it's creating that irritation. If you have too much limbal clearance, that can create a swamp under there as well, and that can create it. So I really think just look at the limbus. But the key is, how do you know that that's there? You have to take the lens off and you have to stain the cornea and make sure you check to see what's happening underneath this cornea. Conjunctival staining, okay, so outside of the area. So we either have impingement that's happening with the scleral lens, or we don't have enough coverage, right? When you think of that dry eye patient that has that staining all over the eye, you want to, again, be thinking about a large lens that's going to cover more of that area so you get more fluid covering that region there. I also want to be thinking about that lid margin. Remember that very first slide that I said the most important thing that you have to do first is clean up the edges, clean up the lids, clean up the lashes, because if you don't, all of that debris will start rubbing onto the conj and start creating that irritation for you. So make sure that that area is nice and cleaned up. I mentioned hypoxia a little bit, and this is where you have too much negative pressure underneath the lens. The lens is too tight. The limbal clearance is too high. So when the limbal clearance is too high or the front sagittal height is too high, it creates this seal. And remember, the lens is sinking the longer you wear it. So the longer you're wearing it, the seal becomes tighter and tighter and tighter, and that creates this pressure underneath the lens. So doing pachymetry is really important to make sure your lens is not too tight. Another way to know if you don't have pachymetry and you're not sure if you have hypoxia, if everything is going well and then all of a sudden you're like, why are they not seeing properly? That could be a problem, right? Why? There's no reason for their vision to have changed. The retina looks good. Everything internally looks good. I want you to think about, maybe I've created some swelling underneath the lens. So how do you know? Asking the patient, okay, when you remove the lens, do you see a compression ring all the way around the edge of the cornea? And if you do, that should be the indicator that, hey, maybe this is too tight and everything is just creating that, super tight seal. Think about when you wear socks that are too tight and they squish around your ankle, and you take your socks off and then you've got that ring around your ankle. That same sort of thing, that can lead to hypoxia under the cornea. So you don't have to have all these devices in order to see this. If vision doesn't make sense and it's now poorer than it was, or if you get that compression ring, or they take the lens off and now the eye blows up and it's all red and irritated for an hour afterwards, again, it's too tight. You've removed that push on those blood vessels, and once that comes off, the eye just gets angry and now all the blood starts flowing again, right? So those are some of the key signs to know that you have hypoxia. Midday fogging. Oh my goodness. This is such a problem when it comes to a scleral lens complication, because this can be coming from so many different areas, and it's one of the tougher ones to treat. Now that we have options, we've got really good options. The edge, I want you to be thinking about outwards in. The edge, if it's, too tight or if it's too loose, either of those could create midday fogging. So you've got to look at the edge. And I like putting fluorescein around the edge to see, okay, is there too much fluorescein coming in too quickly? Because then that means the edge is too loose. Or is there no fluid getting underneath, no fluorescein getting under the lens, meaning that everything is too tight? If it's too tight, what's under there is starting to build up, the negative pressure, the swampiness starts to build. If it's too loose, the tears and the fluid under the lens are exchanging too quickly, and maybe all of the debris from the dry eyes is now coming underneath the lens. So this is a really common problem when it comes to dry eyes and all of that debris coming underneath the lens. So you got to, again, look at the lids. If the edge is lifting and every time you blink, the lid is hitting that edge, then that's going to create a mechanical irritation. And that irritation can start to build more mucus and more debris inside the eyes. So if unnecessarily you're saying, look, the lids look good, but why are we getting this debris? Check your edge, because that may be creating some irritation as well. Solutions are, again, a really big problem when it comes to this. And makeup. I want you to be thinking about both of these things, because if solutions and makeup are not right, or you've got like too much mascara or things floating in the tear film, that can also get underneath the contact lens as well. Solutions. So this is a problem. So, you have a patient who's now out of warranty and now you still have a fogging issue. One of the tricks is to try and change the solution that's inside the bowl and maybe go with a new product. One of the new products that come out is called Neutrophil, and Neutrophil has a different pH than some of the other products. And we have found that that has actually reduced midday fogging, I think by like 30%. So if you see that, that might be a solution for you. The other thing is, okay, in Canada, we don't have access to as many solutions as they have available in the United States. So I've had to be creative. And some of the things that we do is we put a thickening agent into the bowl before we put the lens on. So before we put the sodium chloride in, we put something thick, like a Celluvisc or, a thicker gel, not an ointment, but something thicker. Then we put a couple of drops in, and then we pour the sodium fluorescein in, and then we put the lens on. We don't need to fill the entire bowl with that thicker agent, which is usually end up being a little bit more expensive, because 90% of what's in the bowl is going to fall out anyway. So you want just the thickening agent right at the bottom, and then you fill it with the rest of the sodium chloride. So why do you do that? Because the tears are slipping out, right? The fluid is slipping out and your tears are coming in. But if it's thicker under there, it's not going to exchange as much. So you can reduce some midday fogging that way. Front surface debris. Okay, so this is really, really common when it comes to dry eyes because of all the debris and lack of blinking that happens with dry eye patients. So I always talk about about this as being a potential problem for our patients with dry eyes specifically. What does this mean? This means that maybe halfway through the day, they've got to take the lens out and they've got to clean it, refill all the solutions, and then put the lenses back in. But if they know that from the beginning that one of the complications of having dry eyes is this could be one of the issues, then they're prepared for it. I don't want them to think, you know what, I'm going to guarantee that you can wear this lens for 14, 16 hours a day with no problem. That's not the reality of it, right? So again, going back to that same cleaning up the lids, making sure that's okay, making sure that what they're using on their hands is not creating this front surface buildup, and making sure that they've got the right solutions that they're using. When I think about how do we clean this up, because some people will say, I don't want to take this lens off and I don't want to be creating, I don't have a setup where I can take it off, clean it, and do all this during work. So one of the techniques is that I use my removal tool. I put a little bit of solution on it, sodium chloride, BioTrue, or, an artificial tear just on the tip. And I use it like we are cleaning the windshield of a car. And I just move that edge of the lens or the edge of the DMV over the front of the eye to clean up the lens. And it can really make such a difference before and after of how the lens looks. The materials and the coatings are really important because you can play around with these to get the right type of material to prevent these coatings. We have access to HydroPeg, and HydroPeg has really been a good addition to the practice. I'm going to say that not everybody that has dry eyes do I put HydroPeg on. I will only add HydroPeg if I see, because we're going to be doing maybe 1 or 2 lens exchanges. So again, I'm not going to put it on everybody, but in that first round, I'll leave it off. And if I find that, hey, let's see if this can help us, then I'll add it on there as well. Bubbles under the lens. So this is, I think, one of our last complications. This tends to happen if the lens is not being put in properly. So if the lens is being inserted at an angle instead of coming straight on, air bubbles are coming into the edge. Maybe the edge is too flat and air is coming in and sneaking in. So it's usually ending either the lens is not being put on properly or the edge has a problem and you need to just steepen it up because it's a little bit too flat. One of the things I want to tell you is when it comes to fitting scleral lenses, in my first year, it took me 6 months, 8 months, a year to fit a scleral lens on one single patient. We didn't have the technology, we didn't have the knowledge, we didn't have the resources to be able to fit lenses. So there was so much learning going on. But overall, when you are starting fitting scleral lenses, it's something that does take time. I used to come in after hours. I used to come in on the weekends to spend more time with people because this was something I had to learn. But now that I know how to do this, I go much faster, and I've now been able to build a team that can help me. Really take your time and just go slow and learn what you need. You have a lot of people that are here to help you. You have your labs. You have so many colleagues around the world that are just, one of the best things I love about our profession is how much we are wanting to help each other to become better at helping our patients, right? Going back to that primary mission of the fact that we can do so much to help our patients and really make a difference. So you've got lots of people that can help you. You have the Scleral Lens Society, you have GPLI, you have meetings, you have association. And I love the fact that Zoom has brought us all closer together so that we can share ideas from around the world together. With that, I want to say thank you. And let's use the rest of the time to go through some of these questions that we have. I'm going to hand it back over to you.
Yeah, thank you so much, Dr. Pal, for that very comprehensive talk. I think it was really important for us to go through your idea of fitting, plus you also talked about complications as well. That's really something which we kind of forget, that scleral lenses are the best, of course, but then you must be careful about the complications and how to manage them. That's a very important tip as well, which we could definitely take away from your sharing today.
I agree. I think so many people talk about how great they are, but they're not easy and they are difficult. And so, it takes time to learn all the little nuances. And I think the key thing is pick one company, pick one lens, learn it really well with your lab, and, then let them help you to really understand the design. I think that's really important. When I started, I didn't have 5 companies I was working with. I started with one, and I said, let me understand how this all works and how to fix things. And then once I really understood how scleral lenses work, then the next phase was saying, okay, I know what I'm doing, but now I have a patient where this lens doesn't work. I need something else. And that's when I brought on the next lens and then the next lens from there.
We already had a couple of questions while the presentation was on. Okay, this one. So the lens rotation thing. So you did mention that you want to check about the lens rotation on eye and see if it relocates back. What is exactly you're looking for about the resistance, and what is the acceptable or not acceptable thing which should happen?
Yeah, it's a really good question. So before I had the ability to look with my OCT of whether a lens was too tight or not, I just had to look under the slit lamp. And when you put your finger just at the bottom of the lens and just move it, if the lens doesn't move at all, that's too tight. It shouldn't be so loose that it's spinning, right? If you blink and that lens is moving, that's too loose. But it's really to check to see, is there an edge that maybe is stuck? If you don't have the device to be able to look at all of those specific regions, it's just to give you an idea, hey, is it too tight? And should I start looking for something? It's very hard to quantify. I know I'm not really totally answering the question, but it's very much, if there's no movement, that's not a good thing. If it feels like you have to put pressure, that's also not a good thing. It should have a little bit of resistance, but you should be able to move that lens very nicely and smoothly. It's the same thing as removing the lens, right? If you have to create those bubbles and then push to get the lens out, that's too tight, right?
All right, okay. So it's more of a subjective analysis compared to what we do. And, like, for example, when we do a push-up test to check for soft contact lens fitting, we want to see how freely the lens moves. That is what we are doing here as well.
Exactly. Yeah. When you are looking at a lens that has astigmatism in it, right? Or you have that marking and, we want to move the marking to a different spot. Let's say we move it from 6 to 3. I want to see how quickly is that going to come back to its natural spot, right? Within 15 minutes, it should come back to that 6 o'clock position. If it's stuck there and it doesn't come back, that means that lens may be a little bit too tight as well. So if the patient puts the lens on and it's not in the right spot, it's going to take a long time for it to come to the right position, or it may not at all. So it gives you, again, some ideas of, what's happening underneath the lens that you can't see.
Great. Okay. And do you usually calculate the changes of measurements of OCT about the refractive index? Is there anything which you would consider, probably in terms of material or refractive indexes?
I don't. I don't look at that as too much. I honestly don't.
Yeah. Okay. Probably it doesn't make much of a difference in terms of clinical practice. Is that why we are not looking at it very routinely, I would say, because the trial lens material would probably be similar in terms of the final lens material, right?
Mm-hmm.
Yeah. Have you observed that putting these microvolts and channels have caused impingement, or how would you specifically give indications to the lab on creating those?
Yeah, it's a really good question. So when you look at that microvault, right? So you create this hump, and here where the hump starts, that's where the impingement can create a problem. So, the other part of a microvault being problematic is you create too high of a hump, and now you have all this fluid rushing in. So how I deal with this is, with a specific lab, I ask them, how do you want me to measure what exactly you want? So for one of my labs, for example, they will say, okay, tell me how many degrees you want the microvault to be. 10 degrees, 20 degrees, 25 degrees, 30 degrees. What's the span of it? And then how high do you want it to be in terms of microns? And to learn that, it's very difficult. You're just eyeballing it. So that becomes more practice, where you look at this pinguecula and say, okay, I think that's 100 microns. I think that's 200 microns. And you design it, and then you bring it back. The degrees you can easily measure, right? That's clock dials. But the height is a little bit trickier. And so you just have to trial and error, and by learning and doing more experiments. The key thing with that is, if you're going to go down that path, talk to your lab and involve them, because when they know you're experimenting with things, they will be more lenient with helping you do redos, because some are very strict. You get 1 redo, 2 redos, that's it. Others will say, no, let's try something new. We'll give you 3 redos, 4 redos, whatever we need. But when you bring the lab involved and you're working with a consultant, then they're invested and they will help you more. So, yeah.
Yeah. I think a lot of experienced professionals like you have already made it a point that be friends with your labs, because they are the ones who will be guiding and helping you. So I think, thank you for reinitiating that thought again. Yeah.
Yes, absolutely.
Yeah. And what's your best way of lens insertion? Because, as practitioners, we might have difficulty in inserting the lens. Is it you are somewhat a finger person, or you are a plunger person, or what's your preference?
Yeah, so it's a good question. So my first technique is using the plunger. And when I'm putting the lens on the patient, some people will do it in the chair, where they put a napkin down on the patient and they'll have the patient sit over in the chair. I have the patient stand up and bend over. And so literally they're standing and bending over, and then I'm going from underneath and spreading the lids and then coming in from that side. If the lids are really tight, and I'm talking about me inserting the lens for the first time, if the lids are really tight, then I will bring my technician in. She will hold one lid and I will hold the other, and then we'll put the lens in that way. So we'll use 2 people. But I think remembering to tell your patient to be calm, to breathe, to keep both eyes open. And on the floor, I will point at something, or I'll put something on the floor and say, keep looking at this, so they have something to look at. And then just reassuring them, because they're tense, especially the first time. They don't know what to expect. So all of their muscles are tensing up, and you just need to get them to be relaxed and reassure them that when you put the lens on, all you're going to feel is this rush of fluid on the eye. It's going to be very comfortable.
Yeah, great. And about the filling solution, this is one question which we had got while the registration. So I'm just going to put that across. About the filling solution, when you use the agent to fill up, do you have any complications related to the filling solution? Have you
Yeah.
observed that in long-term effects?
So I've been doing this a long time, so I have not seen any complications, but I am very, very particular about what products I allow my patients to use. Everything has to be preservative free, right? So you can't have preservatives in these products at all. And I think really reviewing and making sure that they are not picking up something random. Oh, I ran out, or this was cheaper, or I found something like that. You just have to keep going over it. But I have not had any complications by using the preservative-free sodium chloride. Some patients will come in with this bottle of saline. Saline is the common thing. It looks the same. It feels the same. It's the same thing, right? It's not the same thing. So, just making sure you review. And, but we've seen irritation on the cornea once, twice. And as soon as I realized that it was a solution-based irritation, now I just talk to everybody right from the beginning and make sure they know that these are the rules and you can't deviate from the rules.
Yeah, I think again, patient's education, like you were mentioning in the beginning, making sure that the patient is aware and follows the instructions. So that exactly makes our life as practitioners much easier, right?
Yes, agreed.
Okay. Another question is, do you do something different in terms of fitting patients with dry eye versus keratoconus or irregular corneas? This is specifically in terms of the sagittal clearance or the vault. Is it higher, lower, or any tips on that?
Yeah, it's a good question. So, with a keratoconic, we are just making sure we don't want to have any rub and touch. So some places I might go down as low as 90 microns, and I'm like, it's okay. As long as we don't have rubbing, we're good. I try to leave a little bit of extra room with them because I want to make sure that the lens will last longer, right? So 6 months from now, I want to make sure I still have 100 microns. So I always plan for a little bit extra. With respect to dry eyes, I want that moisture there to really nourish the cornea, to be helping. And I have seen that when I add a little bit extra clearance, whether it's 50 microns, it doesn't have to be a lot, but a little bit more than I would typically do. So maybe instead of going for 200, I might go for 250. After settling, then I have a little bit of extra moisture because I want that moisture to just be bathing the cornea throughout the course of the day, because we will lose a little bit of that. And I don't want the lens to be removed and to be dry when it comes off. I want there to be fluid underneath the lens. So I do add a little bit extra, or if I see a little bit extra in places, I don't stress as much about it when it comes to dry eyes. But obviously 600 microns, absolutely not. You still are in that 200 to 300 micron range.
Awesome. Great. A couple of more questions before we wind up. Have you experienced patients wearing scleral lenses developing GPCs, and how would you probably manage those?
Yeah. So honestly, I haven't seen too much of it, but the primary reason where GPC is coming from is going to be one of two places. The edge is lifting and you're creating a mechanical irritation underneath the lid. And so you have to look at the edge of the lens and make sure that that is not rubbing up against the lid. And the other is allergies. If you have allergies, it could be allergies to the material of the contact lens. You might want to try changing the material up, especially if they don't have seasonal allergies. And then how do you solve that? Well, one, stop wearing the contact lens and get the whole thing under control. And you can do that with, an antihistamine type of eye drop, and just calming the eye down and getting rid of what's under there. You can use a mild steroid as well. But as long as that edge is under good control, we typically don't see any GPC anymore.
Yeah, great. And just about the rotation technique, what you mentioned, would it be probably possible to do it if the lens has a notch, when you have a pterygium or something like that, or we should avoid doing that?
I tend not to do that when I have the pterygium or the blebs in place, because I don't want that lens to rotate, right? I want that lens in place. And I would do that technique of checking the rotation before I add the notch or before I add the microvault. So my technique of looking for it is when I'm looking at my regular lens before I've added these extra layers. Because now I know that the lens is in the right place and I'm happy with the fit. Then I'm going to add the notch. Then I'm going to add, the microvault. So that comes later on in the fitting process. So my rotation technique, I will do earlier on.
Great. And again, one question which popped up during the registration is about scleral lenses and dry eye patients when you have Sjogren syndrome and severe dry eye patients. What's your experience on using different types of solutions to fill the bowl, such as autologous serum, celluvis, or high viscosity agents? Do you find that helps? And any complications with that as well?
So when it comes to dry eye patients that are like, I'm doing these things and these things and these things and all of this, my goal is to not make it more complicated for them, right? And I also don't want to set unrealistic expectations by saying, you're not going to have to take any of these drops anymore because I'm fitting you with scleral lenses. That's not the case. But what I will do is I will put that autologous serum drop into the bowl of the lens so they have that sitting on the surface of the eye. Remember, these are preservative free. So as long as it's preservative free, we're not doing any harm by having this into the bowl of the lens. So I have no problem with doing that at all. And I've experimented with different medications inside the bowl as well. I tend not to use medications. I tend to typically just go with the autologous serum. A thicker agent under the lens, we talked about it in the presentation as well. It's really good, especially if you have that midday fogging or, you've run out of your warranty and now you're having too much leakage of the lens because one of the edges is too flat. That thickening agent is really good. But yes, I have no problem. Restasis putting into the bowl, putting, the autologous serum into the bowl, no problems.
Oh, great. Okay, I think with that, thank you so much, Dr. Pal, for that very informative session. Thank you so much for answering the questions and sharing your experience with us.
Oh, you're very welcome. Thank you so much.
We do have session planned next weekend. Until then, take care. Be safe. Hope to see you next weekend. Bye-bye.
Thank you, everybody. Bye-bye.
Bye-bye. Thank you, ma'am.